Welcome to Lean Israel's webinar, Transforming Healthcare, How Lean Can Support a Healthy Bottom Line. I am pleased to be hosting this exciting webinar with our guest presenter and partner to the Lean Healthcare Transformation from the US, Kathy Foreman from Virginia Mason Institute. For those of you who don't yet know us, my name is Kalanit Rosenblum. I am a senior Lean leader and the head of Lean Healthcare at Lean Israel. Virginia Mason Institute and Lean Israel established a unique collaboration, utilizing the advantages each has to offer to Israeli healthcare providers. This collaboration combines vast knowledge in healthcare and hospitals around the world, including a live Gemba at Virginia Mason Medical Center and coaching by medical professionals with extensive experience in implementing lean culture in various Israeli organizations, speaking Hebrew, and being a part of the local culture, which has a crucial impact on the implementation success rate. I'm excited to introduce Kathy Foreman. Kathy is a registered nurse and holds a master's degree in health administration. Kathy was Virginia Mason's Senior Vice President of Patient Safety from 2001 to 2015. She is now an executive sensei at Virginia Mason Institute and a certified leader in the Virginia Mason production system. Today, Kathy will present for the next 30 minutes. Then we will move into a Q&A session, questions and answered, for approximately 20 minutes. Some of you sent us questions in advance. You're also welcome to submit any questions throughout the session using the chat box on your screen, and we will address as many questions as possible. Today's session is being recorded. The link will be shared with you and will be posted on Lean Israel website. Thank you for attending. I will now hand it over to Kathy to begin the webinar. Enjoy.
Well, thank you. It's my pleasure to share with you the story of Virginia Mason Health System and our journey using Virginia Mason production system. A little bit about Virginia Mason first. It's an integrated health system located in Seattle, Washington. We have two hospitals, one in Seattle that has 336 beds and one in Yakima on the other side of the mountains that has 226 beds. We also have about 40 medical clinics and almost 1,100 employed physicians and 8,000 employees. The medical center began our journey in 2002. By 2008, we were getting so many requests for visits from other healthcare organizations who were trying to see how a manufacturing system could be implemented in healthcare that we established the Virginia Mason Institute in 2008. The faculty at the Institute have over 300 years of experience applying lean production to healthcare. We have diverse backgrounds, nurses, physicians, and operational leadership who work with organizations across the globe to help other healthcare organizations use lean production to transform healthcare. Just some quality and metrics that we have been watching over time. We call these some of our big dot metrics to share with you some of the things we've been able to do in this journey since 2002. For example, in our hospital, nursing time is our probably most expensive resource that we use, and by applying the lean production system to hospital nursing, we were able to reduce nurse walk distance by over 750 miles a day, which then freed up nurses to be at the bedside greater than for a 60% improvement, which is where our nurses want to be, and good science that shows that if the nurses are at the bedside, nursing clinical outcomes have improved. Another area where there's much dollars wasted is in the time of waiting for operating rooms to be cleaned and ready for the next case. And applying our management system, we were able to reduce the time for turnover in the operating rooms from over 68 minutes to about 10 minutes, all while improving quality and improving patient safety. So this is a conceptual framework that we often use when we're speaking to clients from across the globe about what it takes to transform the way you produce healthcare. So think of this as really producing healthcare in a different way. There is an improvement method. We have chosen the Virginia Mason production system, which was adopted from Toyota. But that in itself is not enough because, as you probably are well aware, unlike manufacturing, healthcare is very much human dependent. It's a human taking care of another human. And so we feel very strongly that besides learning about a production system, you need to address the human dimensions of change. For us, these 4 green bubbles is really how we have gone about addressing the human dimensions of change. And I noticed that some of your questions certainly address some of those areas. So we'll talk a little bit more about each one of those. So first of all, the why. Why did Virginia Mason decide to use a manufacturing process to produce healthcare? In the year 2000, we were experiencing both external and internal change that was very significant. Our area in Seattle, Washington was highly competitive. We had come off really a decade of poor performance with the 1998 and 1999, we were operating in the red. The large healthcare system up the street wanted to buy us. We wanted to stay independent, but our board really asked, can you survive in this environment? At the same time, our CEO of the past 20 years stepped down, and Gary Kaplan became our new CEO. And he recognized several things that we needed to do. So we started down the path. So how did we do it? The first thing he recognized is that we did not really have a strategic plan. And in order to go through such a significant change, he needed to have the entire organization understanding where we were going. And we decided that we wanted to be the quality leader. That was our goal. This is a strategic plan that was designed in partnership with our board, some physicians, and the executive team over a period of a year. It was really important to put it all on one page so that every single member of Virginia Mason, whether you're a housekeeper or a physician, understood the direction we were going. Now, when we started this, we didn't have the Virginia Mason production system at the end. While this was being developed, our executive team went looking for a different way to produce healthcare, to figure out how we were going to do it. As we were trying to figure out what was going to be the production system we were going to use, we were also working on aligning expectations. In the United States, and I believe this is to be true in Israel, the physicians really came from a culture of implicit expectations. We were in the process across the country of purchasing physician practices, but it was not clear what they could expect from the organization or what the organization could expect from them. So we went through a process of having physicians really in an iterative way help us understand what they needed from the organization to move us forward and what we needed from them. So this took a while, but we continue to use this for recruitment, for annually as far as physician evaluations. It is part of the conversation about, are we supporting you, doctors, and doctors, this is what we expect of you from an organization, and what happened here. So it's been a living, breathing document that we continue to use. So we spent, as an executive team, about 18 months looking for a different way to produce healthcare. For those of us who've been in healthcare for a period of time in the 80s and 90s, we tried total quality management and continuous improvement, but it wasn't sticking. And we knew that with the financial pressures in the United States and quite honestly, our failure from a political system to agree on a healthcare system for all, we need to figure out a way to reduce the costs and improve the value of what we were providing for our patients. So we spent about 18 months. First, we looked in healthcare in the United States, in the big names, Cleveland Clinic, Mayo Clinic. And we realized they weren't doing anything different than we had been trying to do, and that was not going to be the answer. So we landed on the Toyota production system, because when we found that, this slide actually comes, these 5 elements are exactly from the Toyota production system. The only word we changed here was the word patient. Their word was customer. They were also focused that the patient is always first in everything they do. For them, it was the customer. They wanted to focus on the highest quality and safety by engaging all employees. And through that, the aim was to maintain a successful enterprise. So when we saw those 5 bullets and we compared it to our strategic true north, we felt, okay, we've found a way to do this. So focusing on quality and safety was absolutely paramount to reducing the costs of healthcare. There is so much cost and waste in our healthcare systems, and this really became so evident when we were at the Toyota Motor Company. This is a photo from the Prius factory, where we were seeing multiple times in a period of moments high school trained assembly line workers not only empowered but held accountable to slow or stop the line if, for example, they were having difficulty putting in a steering wheel, because it was more important for them to make sure that they fixed that before passing it on to the next assembly line worker. Their focus on respecting each other was important, and that quality was more important than the cost. And this was, imagine a factory of that was multiple football fields long, and there's 300 to 350 cars at any given moment, and any worker could stop the line in order to fix something. And in healthcare, we knew that that was not the case in our culture, but that's because our patient was at the top of our strategic plan. We needed to try to change that. So we implemented, when we came back from Japan, what's called the Patient Safety Alert System, which is really a way of engaging every single employee to be safety inspectors, asking them to signal us when they found a system or process that was broken, because only then would we be able to improve those systems and processes, getting out the waste, reducing the cost. And I'll be speaking in much more detail in a conference in January, but this alone, I could spend an hour on this slide, but suffice it to say, it's a major way that we have found to be reducing the unnecessary costs of healthcare. In order to understand what systems and processes need to be fixed, you have to engage your employees. So we have trained all of our people in the Virginia Mason production system, which is VMPS stands for Virginia Mason Production System. And we ask them to tell us, what are the systems and processes that are getting in your way, or only by the grace of God did you not hang that bag, the wrong bag of medicine to that patient. So we often talk about the production system being top down and bottom up. It's the leadership who drive the priorities, but it's the people who are actually doing the work that tell us what's broken and how to fix it. So we engage them in everyday lean, which is ELI. Tell us what ideas you have for fixing this issue. And a rapid process improvement workshop is when we take a week out and we give people the time to work on their work. And then Kaizen is another way to improve things. It's 1 to 3 days. So we're actually taking people, our employees, our physicians offline with very focused efforts and data. It's all data-driven, which is much different than the TQM of the 80s and 90s, and ask them to tell us how to fix something. A critical component of the production system, and Taiichi Ono, who designed the Toyota production system for Toyota, said, if you do nothing else, relentlessly drive out waste. And think about your own systems and processes in your organization. How much waste do each of us experience every single day? The waste of inventory. How many of you in your organizations have had medicine or expensive cardiac stents that become expired that you have to throw out? How many times, if you're in the clinics, do you go in and out of an exam room because you don't have what you need? How many times are you overproducing something just to put it in the recycling box? So if you can focus on the waste of your process that we define as any item or task that does not add value from the perspective of the customer, in our case in healthcare, the patient, that really drives down the cost and improves the value of healthcare. Now, what we didn't get from the Toyota production system, we had to design ourselves, because we were the first healthcare organization to implement the Toyota production system to healthcare. We needed to better understand the flows of medicine. So think about whether it's a patient in an inpatient stay or a patient who is entering your clinic. From the time they come into your system until the time they depart, there's the patient, yes, and there's the physician or the nurse, but what are all the other things that must flow perfectly without waste in order to have that perfect patient experience? The flow of medication, the flow of supplies. How often are your nurses going in and out of their patient rooms trying to find dressings to take care of a wound? Do they have the equipment they need, whether it's an intravenous pole or an Alaris pump? All that time and motion of moving in and out because they don't have the flow of equipment, the flow of supplies. And with the advantage of healthcare, electronic medical records, there's also the flow of information. And do you have the information that you need just when you need it, where you need it? Another critical concept of the production system that's applied to Virginia Mason production system is mistake proofing. Now, there's a lot of, having led the patient safety work for 20 years, we know that we hurt patients. Each of us in healthcare have probably experienced where we have made an error and harmed a patient. When we started focusing on zero defects, it was hard to imagine how we could get to zero defects. And we're not there yet by any means. But we also recognize that because healthcare is such a human-dependent process. And we know that humans make, on average, 6 mistakes a day. We had to differentiate what's the difference between a mistake and a defect, which means focusing on your culture so that it's safe for that nurse, for that medical assistant to raise their hand and say, oh my goodness, I just gave this patient the wrong medication. Because that's how you find what are the systems and processes that are broken that you need to prioritize to get fixed. And we differentiate a mistake from a defect. An example of that is we know that the anesthesiologist needs to instill antibiotics before heart valve surgery. And if that anesthesiologist forgets to start that antibiotic, if you have a culture in which the circulating nurse or the surgeon will stop and pause and allow that infusion to take place, then the patient is not going to have that defect that requires 6 weeks of antibiotic treatment after the surgery. It can be something that can be fixed in the moment. So some of the examples of how we have reduced cost and added to our bottom line has to do with specifically the patient safety program. And what you're seeing here on the green bars is the number of patient safety alerts that our people tell us. So this is, I just made an error, or only by the grace of God did I not make an error, and we fixed that. As those reports go up, the number of lawsuits and claims have gone down significantly. And the United States, because we are such a litigious society, that has been significant. And we know there's good evidence in the United States that only 1 patient out of 8 who's been harmed will actually file a claim or lawsuit. So we know that this has really helped us be our early recognition program to apologize to the patient and family, to make sure that they have everything that they need, and then we have fixed the problem, which has then led, in our organization, we are self-insured to several $millions a year for our hospital professional and general liability premiums. And this is hard green dollars to our bottom line. Over the period of our production system, we have seen a 75% reduction in our premiums since 2004, which has added up to about $5 million just in premiums. And most importantly, we are improving the quality and safety of the care that we provide to our patients. And we've had multiple national recognition for our quality and safety. And we're not done yet. We have more to go. Our patients are telling us that they're happy with what we're doing. They're much more likely to recommend our hospital and clinics, which is a metric that we measure for loyalty. And remember, we came off a decade of poor financial performance. Since we have implemented the Virginia Mason production system, we have been in the positive since then. This is our financial experience through 2015. In 2009, just to point out that one big bump, that's when we took down about $15 million in reserves, again, based on the improvement in safety. We were able to, reserves that we had set aside for claims and lawsuits, we were actually able to put to the bottom line and invest back in our company. And more, as important, the yellow horizontal bar is what we call our shared success program. And so we actually have been able to give back to each individual employee a separate and distinct check from their payroll with a thank you, that your ideas, you're telling us what to improve, what systems and processes should be improved. We give them back a separate check. And you know, it's not as significant for our highly paid staff, but when you're giving a separate check of, for US dollars, $600 to $800 to a housekeeper or to a receptionist, that's really very significant and helps get them more engaged in giving us the ideas for how to improve our care. And with that, I'm going to turn it over to Colleen.
Thank you, Kathy. Before we move on to answer your questions, I'm excited to announce that Kathy will be presenting at our annual conference on January 31st here in Israel. She will talk about transforming the Israel healthcare system using Lean, and will be leading a case study session on the implementation of Virginia Mason's patient safety alert system, which she talked about briefly before. This will be followed by a roundtable discussion on designing care processes around patients, increasing quality, and reducing the cost of care through the adoption of a Lean management methodology. To learn more, feel free to contact Lean Israel office or me directly. We will now start the Q&A portion. Please submit questions via the chat feature, and we will answer as many as possible. We'll start with the first question. What are the first steps in implementing Lean in a tertiary hospital with over 1,000 beds? And what are the minimum essential factors without which a Lean healthcare implementation is doomed to fail?
Well, thank you for that question. And I really do believe that is an incredibly important question. What we would say, and what I have experienced and others at the Institute has experienced, that organizations that try to implement Lean production without addressing those human dimensions of change, changing the culture, and having leadership drive a different way to produce healthcare are essential. What we find is organizations who say, my counterparts, a quality director or a quality, if the vice president of quality is leading this work rather than a management where both clinical and operational people are applying Lean production to all of the systems, that it doesn't work very well. And those organizations have a hard time sustaining the improvements over time. And so we often have organizations who come back and say, how do we sustain? And we would say it's by adopting it as a management system rather than as a project that you just do over here.
Okay, we received another question. What were the main obstacles Virginia Mason encountered, and how did you overcome them?
Well, as you might imagine, our healthcare group would say, how can you possibly think about implementing a manufacturing process to healthcare? People are not cars. And it's true, people are not cars. But the systems and processes in healthcare are often very production-based. Think about the operating room and all the steps that it takes to bring a patient into the operating room, to get the room ready for them, the instruments that are necessary, to time that completely, yes, and actually do the case, but then how they move either to the inpatient unit or get discharged. All of those are process steps that require engagement and support. I'll be real honest with you. When we started, not all of the executive team and not all the physicians were on board with this. And we really didn't know what we were doing because no one else in healthcare had tried this. So we just felt that we needed to start. We had a CEO who was very supportive. We knew, we made the determination that this was a long-term commitment. We weren't going to try for a year or two and then move to something else. In fact, some of the obstacles, you know, with that culture and the pushback, there were people in our organization who thought, okay, this is the next flavor of the month, and I can just hide in my corner and then it'll go away, like so many other things went away. And in actuality, when we continued to go down the path, even though we had bumps, about year 3, about year 4, there were physicians, there were others who said, hey, I really don't know that I can work in this organization. And so we had to hold to our commitment and accept that some people may leave the organization. A huge obstacle at first. When I implemented the patient safety alert system, we thought, okay, this is it. We've figured this out. We're finding the major safety issues. And then we had a death where we caused a patient grave harm. And that really, that was in 2004. And our board could have said, well, this isn't a safe organization, but we recommitted to applying the production system and changing our culture and moving forward. So it requires a huge commitment, and it is not, it's not easy.
Okay, the next question, how does Lean apply to a mainly socialized healthcare environment, such as Israel, the UK, etc.?
Yeah, well, you know, we actually have clients from several countries who have a nationalized or socialized healthcare system. It doesn't really matter how you get your money. The fact is, in healthcare, there is so much waste in our systems and processes that this can be applied. The waste of overprocessing, the waste of too many resources or not enough resources, or using highly trained physicians to do things that are not needed from their training. So one of the things that we've applied a great deal to reduce the cost and to improve quality and to engage our employees is to make sure that everybody is working to the top of their license, so that nurses are getting to do nursing work versus hunting and gathering and running around for supplies. That medical assistants get to do what they were trained to do. And then we have our physicians doing only what they've been trained to do versus wasting their time looking for a piece of equipment or waiting for an anesthesiologist to walk into the room, or other examples that you might imagine. So whichever, and we see this over and over again in our clients in those systems, that they have similar issues where the patient is waiting for, and their patients are unsatisfied because they had to sit in a waiting room for hours waiting to have that mammogram, or they're not getting the services in a timely manner, and then they end up with cancer, and so the cost of treating something that could have been prevented. So it's switching from a reactive to a proactive approach by reducing the waste and focusing on improving the patient experience and quality.
Our next question is about the nature of the collaboration between Virginia Mason Institute and Lean Israel. I'll actually start by saying that Virginia Mason Institute and Lean Israel established this collaboration based on shared lean principles and passion. Both companies have vast experience in implementing lean, and we believe that this collaboration enables healthcare providers here in Israel to receive the vast world knowledge and experience in healthcare with a local presence. And so this joint value proposition includes a few things. We have an executive lean leadership retreat at Virginia Mason in Seattle, a 4-day executive retreat to basically see and feel a mature lean culture in a healthcare setting, and also engage peer-to-peer with Virginia Mason executives. We also offer workshops and lean healthcare training, either in your organization or at Lean Israel Academy. We offer optimizing specific processes using the VSM methodology, value stream mapping, and of course, building a culture of excellence in your organization, infrastructure, and implementation of a lean culture.
Yeah, and just to add to that, I think where we're really aligned, that the partnership works well, is that we're really both understand the importance of changing the culture and aligning leadership to apply the management system as a way to do business. We often tell our leaders, you're responsible to run your business and improve your business, and by applying the production system. And it doesn't matter whether the leader is in our billing or whether it is part of our information technology department or in clinical care. We all use the same method and tools, which allows for that common understanding of those different divisions, if you will, and all on focusing on improving the patient experience.
Moving on to our next question, can you give an example of this work that has reduced costs?
Happy to. Actually, one of the value streams that the organization has been focused on, and I would imagine it's the same in Israel, but in the United States, are supplies, medical supplies, our drug supplies are a growing expense that we've wanted to reduce that growth. We used to plan on a 3% increase in expense for supplies. One of the value streams that we have been focused on for several years now is the supplies of those products, whether it be in the operating rooms, supplies of paper, whatever. And now, as we focus on our budgeting process, we actually plan for and achieve anywhere from a $2 to $3 million reduction in cost every single year on supplies. One example of that is surgery case cards. There was a huge amount of waste in the processing of a surgery case card. So if it's a complicated surgery, say it's a spine surgery, sometimes there's as many as 15 case cards that would be sent up from our sterile processing area to the operating room. And the time and effort that it took the scrub tech to get all of those instruments set up, just to learn that the surgeon may only use 10% or at most 20% of what was sent up in the case card. And then all of those instruments go back down to the to be cleaned, etc. But because they came back down, they all have to be processed. So that's a really good example of over processing, transportation, and quite frankly, for Virginia Mason, we saw significant reduction in our workers' compensation because the heavy equipment really impacted the injury rate of the sterile processing team. So the surgeons, the central processing team, and the the circulating nurses have all teamed up to reduce the total instrument count and reduce the setup reduction from an hour down to about 30 seconds. They've got the number of instruments down to a very small amount that the scrub tech, all they have to do is just pick it up and put it on the back table and they're ready to go.
Wow, that's a great example. Our next question, the hospital features multiple technologies and methodologies. How the lean methodology addresses this issue?
Yeah, so one of the reasons why we believe it is so important to consider this a management method, what our Japanese senseis or teachers told us from the beginning is that don't believe anything on the computer, throw it all away and go and see what the system or the process is. Now that seemed, even in the early 2000s, seemed very ridiculous. But one of the things that we learned, remember I was talking about the flows of medicine, to really understand what the processes are. So our information systems department, again, also uses our production system, and they work with the clinical team to understand what are the flows, what are the processes that they need to consider when implementing a new technology. So they use these rapid process improvement workshops or Kaizen events and engage the staff. Well, how do you use this particular technology? How do you go about doing your morning assessment of a patient? And they fully understand that before they design or implement a new technology. We did a lot of work using, I think we must have done about 12 different rapid process improvement workshops in inpatient nursing before we implemented barcoding for medication administration, because we needed to really understand the variation of how nurses prepared for and did medication administration to really understand and eliminate the potential workarounds that nurses are so well known for. It's another example of how we use that methodology.
Our next question is actually about engaging physicians. How do you best engage physicians in consideration of their time constraints and general disconnect from operations?
From the very beginning when we started on this journey, Gary Kaplan, who is a physician, our CEO, recognized that even though an individual physician may not be in a formal leadership position, any physician is an informal leader and role model for the rest of the organization. So that is why we spent so much time creating and implementing the infrastructure around a physician compact. It's slow. We submitted it. So now we use that compact when a physician or physicians do not want to support, say, the standard work or the new way we're going to do case carts for spine surgeries, for example. If one of the spine surgeons said, I don't want to do this, we would use our physician compact, and the physician leader would have a conversation with that surgeon and help them to understand what their responsibilities are and what the organization's responsibilities, to listen carefully. What is it about this new standard work that doesn't work for you? And most often, there's some ownership on both sides, both from the organization and the physician. We use it a lot also with our patient safety alert system. When there has been a, say, disruptive behavior of a physician, almost always the organization has failed that person in some way. But then also they are held accountable for their behaviors, and we work together to move forward with improving. they can't get on board, then, you know, as I mentioned earlier, we did have a small set of physicians who left the organization. And now we're really clear from when we're recruiting physicians, this is our compact, this is our strategic plan, this is how we work as an organization, and our culture is very different than most hospitals you've ever worked in. Before they sign the contract, we send the compact again and say, remember, this is the organization. Are you committing to this compact? And then every year, as part of the performance evaluation, it is again raised and talked about. From a physicians who have formal leadership positions, they are required to be trained in the Virginia Mason production system and apply this to their work, because again, this is a management system. And so anybody in a management role, whether you're an administrator, a nurse, or a physician, the expectation is that they're using the production system to run their business and improve their business.
Our next question is, how do you balance productivity mandates with the need to engage frontline staff in process improvement?
That's an excellent question. And just to start with, it takes a commitment, and that's why, in my personal opinion, it doesn't work to do this as a project versus a management system. It takes commitment of the organization to free up those individuals to work on their work. And it's quite a gift to have teams from the whole process, whether it's the surgeon who does the pancreas surgery, cancer surgery, to the nurses on the floor, to the induction room. They're all working, and the patients. We actually have the patients as part of our teams. They're all working to improve something. That's expensive. There's no question about it. When you're taking physicians offline, nurses offline, etc., and our teams are generally 8 to 10 in number for a 5-day workshop. The productivity that you gain from that is the reduction in waste. Again, focusing on the reduction of waste of overprocessing, the waste of patients waiting around for procedures, getting rid of entire processes that are determined not to add any value to the patient, or are not required by some sort of regulatory requirement. So we've done a lot to just cut out processes. So it's in the back end. Another thing that we've been able to experience over and over again is, as we're improving these processes and we're getting physicians to do what they do best and nurses to do what they do best, we've been able to reduce or eliminate the need for additional space, additional capital equipment that has added up into the millions of dollars. A good example of this was in gastroenterology. We have an internationally known digestive disease institute, and they were there was more patients than they could keep up with, and so they said, please build us 6 new endo rooms and we would be happy to take care of this work. And when we looked at it, applying the management was that we realized that they were coming in and out doing, because they didn't have what they needed, they were doing work that a nurse could do, and the nurse was doing work that the medical assistant could do. So when we streamlined that whole process, they didn't need any more rooms at all. They were able to meet the demand because everybody was working to the top of their license.
Moving on to our next question about engagement. How do you engage with individuals who are not committed to change or even actively adverse to it?
Well, for us, what we did, we had, so again, it's top down, bottom up. So we had, as an organization, declared certain areas of priority. And so those areas of priority we focused on and understood what we call the value stream. For us, one of them was the supply chain. One of them was the hospital stay. And so we focused on those. So quite honestly, for the first few years, the people in the clinics, for example, could kind of ignore what was going on, and we didn't necessarily engage them. As we turned our sights onto the clinic, then it became, then we provided the resources and the areas of focus to help them understand how they could improve. A good example of how you can engage individuals who are not committed to change, and by the way, we now change so much that we've had to put that into our behavioral interviewing when we are interviewing new people coming into our organization, because if you don't like change, this is a hard place to work because we are constantly changing systems and processes. So we actually select out those that are interested in process improvement and interested in change. At the beginning, we worked with those people. We tried to get them to come along, and when they could see something in their own area that was bothering them, and then they had the opportunity to come up with an idea for how to improve it, that's when they get engaged. I have a wonderful example of a patient care technician in the emergency room who she was so frustrated with the systems that she was having to deal with on a daily basis that she was having performance problems. And so when she got the opportunity to participate in a rapid process improvement workshop and could see how this could reduce waste and improve her experience on a daily basis, she became so committed to the production system. She asked her supervisor, could she be trained in the management system? And she became our first patient care technician who has been certified to be able to run her own events.
Our next question, which will be our last question, also about engagement. How do you engage staff to not complain but offer solutions?
It's a great thing to ask, and with our everyday lean improvement ideas that I kind of briefly mentioned, so there's a structure around it. Give us your good ideas. The framework that we provide, and every single supervisor, manager, director, leadership looks different in this organization now. Instead of solving the problems, we ask our leaders to frame the problems for the people and have them come up with the ideas. The rules around that framing, for example, if I'm a nurse in the urology clinic, it has to be an idea that they have control over. So you can't come up with an idea to tell pharmacy how to fix their problems. It has to be an idea that is within the urology clinic. The leader, the line supervisor, would help that nurse or that medical assistant collect some data. It's very data driven, and say, okay, we think this is a problem. How often does it occurring? So count, and it's not, it doesn't have to be a research project, 5 or 10 examples of frequency and how much extra time did it take, how many defects were there, etc. And then they come up with a solution for improving. They present that back to their team and say, this is my idea for improving. Would you test this? So we use PDSA, Plan, Do, Study, Act, and they test the idea. And if it works, then we celebrate that. And we actually we have what we call a supermarket on our intranet. So anybody throughout the organization can and are asked to look at that supermarket to come up with ideas to implement in their own areas.
Great. So with that, we are concluding today's webinar. As I said in the beginning, the session was recorded. The link will be shared with you and will be posted on Lynn Israel website, along with answers to the questions that were not addressed during the webinar. You can hear more about Lynn Healthcare at our annual conference in January. Kathy will be presenting. For those of you who are considering a lean transformation and would like for your senior management team to meet Kathy and us, please contact us to set up a meeting. Thank you again, Kathy, and thank you to all the participants. Erev Tov.